So I have WM as well. So totally interesting and good for me to top up my knowledge on this. We've got a lot to get through, so I will hand over to Dr. Lindsay, but I just wanted to say a big thank you to her because she's actually on holiday this week with her family down in the southwest.
Oh, so don't say any more because I've got a quiz question at the end.
Okay.
So just for a bit of fun. Yeah, so my introductions are on the screen. So my hematologist I am not Scottish. My husband is 1/4 Scottish. I am Czech, but I've lived in the UK for now 24 years. And I have done all my postgraduate training and work in the UK as a hematologist. So we've got Tony and we've got Susie. So both of you are recently diagnosed WM patients, or?
Yes, 3 weeks ago.
Okay, so very fresh.
Well,
okay.
It's actually December for me, but I just wanted to come along, and I might pick up 1 or 2 important things. Obviously, going forward, I'm still going to have, Waldenstrom. So, yeah, I just thought it might be interesting.
Yeah. So, Waldenstrom's is a chronic disorder, so it will stay with you unless we come up with a cure. But at the moment, we haven't got a cure. So at the moment, it is very likely that you will live for the rest of your life with Waldenstrom's, and hopefully you might never need anything doing for that. But we'll touch on that. Okay, so as I said, Waldenstrom's macroglobulinemia is a type of lymphoproliferative disorder that falls under the umbrella of blood cancer. Cancer is a very powerful word, so I'm trying to use it here and there, but nevertheless, anything which there is an uncontrolled growth of, whether it's just a cell or whether it's a lump of cell, it is cancer. So, and it comes under the blood disorders because it's related to bone marrow, and immunity system. Sometimes people will refer it to this condition as Waldenstrom's macroglobulinemia. Sometimes you can hear the term of indolent non-Hodgkin's lymphoma or lymphoplasmacytic lymphoma. All these things can describe Waldenstrom's. Waldenstrom's in itself, it's one of the lymphoplasmacytic lymphomas which produces the IgM paraprotein. And probably you were told, and that's most likely how you were diagnosed, that the paraprotein was picked up. Quite often it's actually happened on a routine test that we suddenly see that there is a excess of protein. We do test called serum protein electrophoresis, and we find there is a suddenly unexplained overproduction of one particular antibody, and that's called paraprotein. It's a faulty antibody. It doesn't really serve much purpose. But in higher levels can be actually harmful to the body, and we'll talk about that. So most commonly, the main accumulation of these abnormal cells is actually in the bone marrow. So there is an overproduction, overgrowth of abnormal white cells, and these cells, there is a kind of pathway how lymphocytes or immunity cells develop. And in Waldenstrom's, it's a cell which is something between lymphocytes and a plasma cells, which is a mature lymphocyte. So lymphocytes, B cell lymphocytes, can evolve into plasma cells, and that's where the Waldenstrom's happen. So, and these cells are able to produce the antibody. There are you might come across patients who don't produce the IgM paraprotein, or their disease is slightly different. We call these the lymphoplasmacytic lymphoma. Some of them don't produce any antibody at all. The cells have just gone so unusual and dodgy that they are unable to produce any antibody. It's relatively rare. It's only about 1 in 20 patients with a lymphoplasmacytic lymphoma, but we also have patients who have got a LPL which produce different antibodies than IgM, such as IgG and IgA. I personally have a handful of patients with IgA and IgG lymphoplasmacytic lymphoma. This is just the kind of going back to the I think someone is coming in, joining us.
Yeah.
Jane, can I leave you in charge letting people in? This is just to kind of show you what the antibodies are like. So we've got an IgM here. As you can see, it's the largest one, and that's quite relevant. And that's what then translates to some of the symptoms patients can experience. And the IgG and IG, so these are all the antibodies our immunity systems, the plasma cells produce. And typically we've got a variety of antibodies because through our life we are exposed to different external stimuli, infection, viruses, you name it. And as a response to it, we produce antibodies to try to clear the problem. So when we do this test in the lab, which is called serum protein electrophoresis, we see there is a lot of kind of waves. The test is done that you put the serum on a gel between 2 electric currents, and you watch how the proteins actually travel on the gel. And because different antibodies will have different sizes, and that's why they will be traveling in a different speed. And that's how we actually pick up this. And everyone's got antibodies, and you see variety of different antibodies as a normal immunity response. But in Waldenstrom's or some other blood disorders as well, we can see just one peak, and that would just show that there is one abnormal antibody, and that's the paraprotein. I thought I'd just show you some pictures as well, just to kind of remind you. And I'm sure, oh, sorry, and now how do I go back here? I'm sure this is something you probably have in your booklets, or your doctors have shown you, just to remind you the lymphatic system. So the lymphatic system consists of lymph glands, and we know the ones which we can feel. So it's in the neck, armpits, groins. But there are also internal ones, and they are all connected by these little vessels, and they look pretty much like normal blood vessels, but these vessels carry lymph. So the lymphatic system is all connected. So quite often when my patients ask me about what's my stage of my lymphoma, I say, well, it doesn't quite work like that, because as you see, the immune system is one long complicated system. In addition, the immunity system actually is covering us anywhere in the body, because we need it. We need fight infections, and infections can enter the body through different ways. It could be mouth, nose, ears, everywhere. So we are covered with immune cells, and if something goes wrong at these places, then suddenly we can have an overgrowth. So commonly, why me? Why was I diagnosed with Waldenstrom's? What have I done wrong? And the answer is, we don't know. Certainly people have not done anything wrong. It's just bad luck that you have something suddenly went wrong in your system. We do know at the bottom of the slide, see there is some evidence that if you've got a first-degree relative with Waldenstrom's, you're statistically slightly more likely to have Waldenstrom's as well, but it's still the statistics are still so low that I quite often reassure my patients it's extremely rare, and it's definitely not common enough to do any screening in the family and worry the rest of the family. We also know that certain autoimmune disorders, and these are disorders where your own immunity is attacking your own body. Common ones, something like rheumatoid arthritis or polymyalgia or underactive thyroid. These are autoimmune disorders, and there is also an incidence that the Waldenstrom's, it's a bit more frequent in families where autoimmune disorders are present. And its literature also suggests that some infections, some viral infections like hepatitis and similar viruses can also predispose people to developing WM. I mean, in general, in the lymphoma, we do believe that chronic constant stimulation can make the immunity cells kind of be more activated to a point that sometimes something can go wrong, and an overgrowth of one cell happens. So I don't think I need to read the rest for you. I don't know whether you were diagnosed with Waldenstrom straight away, or whether you were observed, or whether someone told you that you had MGUS. MGUS, it's also a word you will see in literature and booklets. It's called monoclonal. It means monoclonal gammopathy of undetermined significance, and it's basically the kind of pre-Waldenstrom stage where there's not enough cells to call it a cancerous condition, but we know that there is already, the family is there and it's evolving, and we monitor with these patients because we know if people live long enough, many of these patients will develop, they will develop Waldenstrom's. I don't know if you want to ask any questions. Just there is something in the chat. Yeah,
I was just welcoming David.
Oh, that was welcome. So yeah, I'm quite happy to be interrupted if you've got any questions which is relevant. Just yeah, don't be shy.
Yeah.
Okay.
I've got psoriatic arthritis, so it's from psoriasis, psoriatic arthritis. Could there be any connection between those two? Could I have got Waldenstrom's from having that arthritis?
It is possible because it's all to do with your immunity system, and obviously your immunity system already something went wrong there because you developed the psoriasis and psoriatic arthritis, so your joints are being attacked again by your own immune system, and it's not unusual to have rheumatoid arthritis and IgM paraprotein or other arthritides. So yes, it doesn't necessarily mean that if you have psoriatic arthritis you develop Waldenstrom's. Not at all, but you know there is clearly evidence that some of these disorders there is a link, and it's just again shows that if the immunity is, if there is some ongoing challenge within the immunity, you know, something can escape and something can start misbehaving, and Waldenstrom's you know, cells suddenly start appearing and producing the paraprotein.
Yeah, the other thing was I was on a drug for about 18 years called methotrexate, and they decided, when they discovered the Waldenstrom's, they decided to take me off methotrexate because there could have been a connection. Do you have any thoughts?
Yes, that's also with these things. I mean, it depends how bad your psoriatic arthritis is. So because we do believe that sometimes drugs can induce certain conditions, certainly patients can sometimes present with quite aggressive high-grade lymphomas who have been on immunosuppression, and the first thing we do, we stop the immunosuppression. So yes, there is a possible link, and that's why the doctors decided to stop your medication. But it's always about weighing the risks and benefits. You know, if your joints go completely bad, then you will need some form of immunosuppression, because Waldenstrom's is something people live with for decades, but you need to have a good quality of life. So obviously your doctors thought about your case carefully and decided that let's just see how we get on without it, in case that's what was the main drive for the Waldenstrom's.
Susie, Susie had a question.
Yeah,
sorry.
Yeah, I just wondered. I read somewhere, because the doctors say that I spoke to, the specialist said that it wasn't likely to be that, but is it Lyme's can cause it? There is a thought.
Lyme's disease.
It's on the
Yes,
internet.
yeah, I'm sure. I mean, the difficulty is we can't say, oh, it is, because we have screened 1,000 patients with Lyme's disease and they had it. We don't have those data. But again, you could have come across a case report for patients who had a Lyme's disease and then develop lymphoma or develop WM. Again, it goes back to the challenge of the immunity system. I mean, there is, just going away from Waldenstrom's, there is a well-established association between infection and lymphoma, and it's something of you might have heard of a gastric lymphoma called mold lymphoma, and it's driven by Helicobacter pylori. So it's a bacteria which infects the stomach, causes ulcers and causes lymphoma. But we also know when we treat and give antibiotics and get rid of this bacteria, then the lymphoma goes away in the stomach. So there is already kind of evidence that infections, whether they are viral or bacterial, they can trigger some reactions within the immunity system and can lead to it. So did you say, Susie, that you were diagnosed with Lyme's? Do you have Lyme's disease? Or
No, but I do live in the New Forest, and so there are, we do get ticks. I haven't had Lyme's that I know of, but 2 years ago I had a blood test for something and they picked up an abnormal number of white blood cells, and they said, are you fighting an infection? It looks like I'm fighting an infection, and I wasn't. There was nothing wrong with me. And so then they tested them again last year, not knowing I had this, by the way, and said, no, they're fine now. That's a bit odd.
Okay.
Then to get this.
Yeah, so again, for me, it's very difficult to comment on a blood test. I don't have access to how abnormal it is. That would be wrong. High white cell count typically means that there is an infection and you're fighting infection, but it could mean sometimes the infections might not even be there, that because your immunity is so strong, something gets into your body and your body is dealing with it. So you don't actually have fevers or temperatures or feeling flu or anything like that, because your body just takes care of it. So it's difficult to say. I mean, there is an easy test to do for Lyme disease, and then you can have a serology for the bacteria to see whether you've ever been exposed to it. But whether that would, I think in the current climate on the NHS, we don't like to do tests which will not affect what we do, because if you're otherwise clinically well, no one would say, well, people would say, yeah, probably you had it and you cleared it. So yeah, it's a possibility. Okay.
Thank you, Lindsay. David, did you have any questions? I know you joined just after we started, so.
Sorry, I'm always late.
That's right.
My history is relatively recently diagnosed, only in this summer or this early spring, perhaps. But I had COVID whenever it was 2 years ago, and that played havoc with me. And I haven't been right since, but with chronic fatigue, really, and any bug or anybody gets a cough or cold that lasts for 3 days, mine lasts for 3 weeks or a month, and I end up having to have antibiotics or something. I guess you could say, talking about how it ever came to be, I had glandular fever when I was a teenager, and that somebody said that Epstein-Barr can be a causal factor. I think that's probably been a little bit of an interference in all my life anyway. But it's subsequently, since COVID has really made me quite tired and lethargic and unable to be fully functional. I'm not one for statistics, but a lot of people seem to know all their figures of what their readings and levels are and everything, and I'm afraid I can't remember, but my consultant says it's not alarmingly high at the moment. So I'm on a wait and see basis, I think.
Yeah, I think we'll get there very shortly to the management, but just a couple of points. Epstein-Barr virus is a common, it's one of those viruses which can be associated with lymphomas in general. We see it in some different lymphomas than WM. We quite often do stain for infection, for EBV infection. But again, as I said before, not everyone who will get this infection will develop lymphoma. And I think about 80% of people will get Epstein-Barr virus throughout their life. So, commonly we do it in a childhood or in a young teenage or young adult age. And only minority will develop lymphoma. But what the Epstein-Barr virus can do, it can actually reactivate when your immunity system is weakened for different reasons. So that sometimes can trigger again something else. So yeah, EBV is definitely something we do hear about and we test for in certain lymphomas. The other comment I'd like to make about COVID, I don't know what happens, but COVID just made everything go completely bonkers. I've never seen so many cases, and even talking to my rheumatology colleagues who treat different disorders, we have seen that it must have somehow shaken the immunity system of people. But it could be the virus itself, but it could be the fact that we were in isolation and we stopped doing for 2 years what we normally do, letting viruses attack our body and letting our immunity deal with what it should be dealing. I don't know. There's obviously, you will have lots of people who will speculate that, well, let's not go there. But certainly have seen a lot of patients struggling with long COVID, post-COVID, and fatigue in particular is very difficult. And it will be difficult and challenging case for your doctor, because what is the long COVID and what could it be the WM, and do I need to treat you or not? So, and in medicine, things are not black and white. So always it's always the way I will look at it in these situations, always a doctor and patient as a team. It's not one or the other making decisions. It's always joint decision and trying to work out like what it could be and what if I do this, what do I do that. So, I think it's going to be challenging if you continue to feel really, really fatigued. But at the moment, 2 years post-COVID, it's not unusual. Unfortunately, there is a lot of people who struggle.
Right.
Right. Well, let's just move on to my next slide. Symptoms. And here we go. This is the fatigue. And it's really difficult. Tiredness is very, very difficult because a lot of people are tired. In modern era, everyone is just overworked. Young patients with WM, working mums with WM. It's very difficult. And how do we know that what is just what it's expected to be, or what is the WM? So it is a very difficult one, but it's just something, again, I ask the patients, always look how you are today and how you were 6 months ago. What could you do? Are you just tired that you need to have a sleep and you feel better, or are you just unable to do things? Are your muscles fatigued? Are you just feeling unable to perform daily tasks? Are you unable to go for a walk, which you used to enjoy? I think these are, and the history taking here is very important. And as again, I said, this is a very very tricky one. The other symptoms which patients can have, it's frequent and long-lasting infections. So, David, that's what you said, that you are having lots of infections. But again, if the infections are not severe enough, which would require antibiotics, admission to the hospital for intravenous antibiotics, we are a little bit careful, because when we talk about the decision to treat someone, then we're going to be giving treatment which might make you even more prone to infections, because with the treatment, there is a collateral damage to the immunity as well. So again, this is a very, very kind of gray zone, and again, it just takes down to sitting down and carefully looking at the frequency of your infection, how it's affecting your body, how it's affecting your life. And again, and then we will throw COVID into the work here as well. And it's difficult. So I think, at the moment, it's probably not a bad idea just to see how things evolve, because you're just newly diagnosed. But, infections and fatigue can be difficult, particularly when there is other risk factors as the recent COVID. But when we truly do talk for patients requiring treatment, I have kind of divided it here to two groups. So the most commonly what we actually see are symptoms of bone marrow failure. So the bone marrow gets really, really stuffed with those lymphoplasmacytic cells, with the WM cells, really kind of crowded, that the red cells don't have all the precursors of blood cells don't have room to grow. So commonly patients will develop anemia, or they can drop their platelet count and develop easy bruising or bleeding, or the white cell count can be low. Unlike Susie mentioned that her white cell count in the past was high, what we would see is actually reduction of the white cell count, particularly the neutrophils. And that's what you probably will see as well. And doctors, hematologists like to mention what's the neutrophil count, because neutrophils are the macrophages. They are the ones which are going to be there as a first fighting infection. If you get tonsillitis, neutrophils be there fighting it. If you don't have enough neutrophils, then the body will struggle to clear these infections. The immunity system is very complicated. There are a number of different cells. You've got lymphocytes which can attack directly, lymphocytes which will attract other lymphocytes, macrophages which will be able to eat the bacteria or anything. So, the immune system is very complex. And by having WM, we already know that the cells which produce antibodies, there is already disbalance. So quite often we see actually reduction of the normal antibodies as well. So you don't have the antibody part of the immunity system. Then if you've got a bone marrow really full of cells and you cannot produce your neutrophils, then that would be another additional risk to infections. Then there is sometimes anemia, and I have actually quite a few patients who will have anemia, and the doctor says, well, it's iron deficiency, you are iron deficient. And that's just something which we call functional iron deficiency, and we see it quite commonly with WM patients. And it's already now understood that there is a protein the WM cells can produce, and this protein then messes up with the way how iron is utilized when it's absorbed through your gut. So it doesn't really go to where it should be stored, and it's not delivered to the red cells properly. So sometimes patients can develop anemia, not purely because of bone marrow failure, but because of the fact that the iron is not making it in the right way to the red cells. What I personally do in these scenarios, I usually try to give patients iron, because sometimes when you kind of overdose someone, really give them a lot of iron, see if they can absorb it, then you can overcome it and you can avoid giving them chemotherapy. But for some patients, it just doesn't work, and that would be reason to treat them, to reduce the number of the abnormal cells in the bone marrow, so healthy red cells can be made. And then at the bottom of the slide, you can see the lymphoma cell, the WM cells can build up in different places, and that's why doctors, when they do examine you, they just check your neck, and you saw the picture there with the lymphatic system. So the glands which we can feel are in the neck, armpits or groins. Spleen can be swollen, and it's quite common as well in WM. You can have the WM cells in the spleen. Quite often the spleen would have to be really pretty big for you to notice, but if patients develop discomfort at what we call it the left upper quadrant, so it's the kind of under the rib cage on the left side, pain, discomfort, or fullness, because it could, if the spleen is really enlarged, could be pushing on your stomach. So when you eat, you just suddenly realize, I can't have my Sunday roast. It's just too much, I feel full. So something which we call, the medical term is early satiety. That would be indicative that the spleen can be enlarged. And as I mentioned earlier, the WM cells can be found elsewhere. It could be found in the throat, it could be found in the lung, because immune system and immunity cells are there as well. These are the kind of little bit rarer locations.
Can I ask a question before you move off of that? The cells can be found in the throat. When I actually, after all the COVID issues I had initially, I had a big lump, well, not big, it wasn't big at all, on my voice box, which they did a biopsy with and said it wasn't cancerous. Could that have been caused by?
It's difficult, David. I can't really provide a second opinion or something like that, because I don't know what if they found there were no abnormal cells. That is very reassuring, and it could have been coincidental, and it could have just been brought on by the symptoms you developed following COVID, that they looked and found it. It is difficult to say, but because they did a biopsy and it was reactive or not abnormal, that's reassuring. So unlikely related.
Right.
Okay.
No, thank you.
So when we talk about the paraprotein, the IgM, it's faulty. It's kind of doesn't do very much for us. But if it gets to very high levels, and by high levels, usually the levels 40, 50, 60 and above, that could cause, you saw the picture, it's a pentamer, so it's got 5 of those molecules, and that is really big, so it will make the blood sticky. And if blood is really sticky and thick, and it just goes through little vessels, say in the head or heart, that could cause kind of slowing the passage, and can be associated with these symptoms, and we call that hyperviscosity. So that will always be the question your doctors will ask you at your routine appointments. Do you had any headaches, any floaters, any visual disturbances? Do you feel out of breath on exertion or on minimal exertion? Do you have blurred vision, nosebleeds, gum bleeds, any bleeding, etc.? So these are the standard questions we ask for hyperviscosity symptoms. And other symptoms. So the other symptoms could include something which we call a constitutional symptoms, or B symptoms. So that would suggest that actually the lymphoma, the WM, is quite active, and it's quite a lot of it, and it will be taking the energy of you, because the cancer cells, they want the energy, they want to grow. So whatever you eat, you will be feeding it, and so that's why patients start complaining of unexplained weight loss. They can have night sweats and fevers, and it's all to do with the release of cytokines, which are proteins from the tumor cells, and these will lead to night sweats and fevers. Sweat, again, it's very common, particularly in the female population. I get asked about it all the time. Unless the sweats are associated with the fevers and unexplained weight loss, they are unlikely significant, because the night sweat, the sweats would be due to release of those cytokines. And if there is enough cells to produce those cytokines, something else will be there. So these are the constitutional symptoms. Then I've got a special interest, or I always found it exciting just to look at these neuropathies. So you've probably seen in the literature something called MAG neuropathy. So patients with IgM paraprotein can sometimes develop condition where a protein related to the IgM is actually attacking the myelin, which is the protective protein on the sheath of the nerve, and causes damage that way. Commonly, it starts at the feet, and it could be just a numbness, but could have problems with balance because the messages from the bottom of the foot doesn't quite make it up to the brain because the nerves are impaired there. So balance issues, numbness, abnormal sensation, that's something which, again, doctors should be asking you at your regular follow-ups. And there are some other symptoms which are listed here, and it's just simply because WM is, or anything to do with IgM paraprotein, it's just, you have got so many different conditions which can happen, and I'm not going to bore you with that, but there are so many different possibilities. I think the crucial thing is, if you develop a new symptom and you don't know, it's unusual, you should always discuss it with your doctor, because it could be joint aches. You could develop rashes, which could be like little red dots. We call it vasculitic rash, like little red dots, or urticaria like rashes can be also associated with IgM paraprotein. Sometimes patients will say, oh, my toes go blue, or my fingertips go white, and on my lips, and it's just really cold. All these things could be linked. So I don't want to give you a list here of rare conditions, but I want you to be aware that IgM paraprotein can be associated with all sorts of weird and rare conditions. And it's always, if you develop new symptom, please discuss it with your doctor. So investigation. So these are blood tests and a clinical examination. It's what would be happening routinely at the beginning when patients are first diagnosed. These are the tests we do. So in a blood, what we want to know is, what's your full blood count like? i.e., we want to know what your bone marrow function is like. If your full blood count is normal, that suggests that you've got a very good bone marrow reserve. Unlikely there is a significant overgrowth of the blood cells, and we are fine. We will check plasma viscosity. Again, in some centers it's done routinely, in some others it's only done if you are suspecting that the plasma viscosity will be elevated. We know that unless the paraprotein is 40 grams per liter and above, we know that's kind of that's the cutoff. It's just relatively safe. But different patients are different, So I had a patient with paraprotein quite low, about 20, and she had severe symptoms of hyperviscosity. So things vary from person to person. Then we will be routinely doing the serum protein electrophoresis. That's the test I mentioned earlier, where we put the serum between two on the gel, between current, and we watch how the proteins are running, and then we measure how large the peak of the abnormal gamma globulin is, and that's how we monitor the WM. If it's growing, we monitor it because we want to know, we want to understand the disease, we want to see the dynamics, we want to try to kind of predict, say, this is moving rather fast, something might be happening soon. But please do not dwell just on the number, because the one number is just one part of the whole picture. We will be taking into consideration so much more, not just the paraprotein, but the paraprotein is an easy tool for us to use to monitor the disease. We will always be checking how your kidneys are working and how your liver is working. And early at presentation, we also check what your blood group is, and we will look for presence of some typical atypical proteins, which can be associated with some rarer conditions associated with IgM paraprotein. So you might have heard that your doctor is doing Coombs test or direct antiglobulin test. It's just to look whether there are there any proteins which could be linked to anemia, etc. Does it all make sense? I feel like I'm talking really fast, so please stop me if it's getting too technical or I'm going on a tangent. I think you probably all had bone marrow biopsy, or maybe not. Yeah. So bone marrow biopsy we do because we wanna confirm, we want to see the cells, we want to see how many cells are there, but we also check for some kind of mutation. So we now know that there are certain abnormalities within the cells which can be associated with WM. So you might have heard of MYD88 or CXCR4. And again, it's not gonna, if you have it or don't have it, it doesn't gonna change what we do at early presentation, but it just kind of helps us, and again gives us some idea how likely you're going to respond to this treatment, what are likely the symptoms you're going to have. So these are the recent advances. So this is kind of helpful for us as doctors to be able to kind of plan ahead a little bit and say, okay, well, this patient has got, is a CXCR4 positive. So yeah, it's more likely to have hyperviscosity or some of these things. So it's just for us doctors to know. But it's the bone marrow biopsy is the diagnostic test to confirm it is Waldenstrom's. It's not just an MGUS, which would be kind of just a few dotted cells around. And then we also do scans. So you can have it just as a standard CT scan, which is looking at sizes of lymph glands, sizes of spleen, or sometimes we do CT PET scan, which is looking at activity within the glands. So some glands can be still relatively small, but they can have lymphoma in it, and we will pick that up on CT PET. And we also talk about some of the neuropathies, or sometimes if there are any symptoms which would be linked to the central nervous system, we would be doing an MRI scan, particularly of the brain. So management. So quite often when we start, unless patients present as an emergency, if it's just picked up on a routine blood test, quite often we actually say we'll see that disease is smoldering. So the patients are well, there are no abnormalities to suggest that the disease is causing any damage to the body. We'll call it smoldering Waldenstrom's, and we will be monitoring patients every 3 to 6 months. Depending, we might start every 3 months, and after a couple of years, if nothing is happening, then we will extend the time. Many patients will actually not need treatment for 5 years from when, if they are diagnosed very early on. So we just try to encourage patients to have as normal life as possible and try to put it on a back burner, but having a routine test and having access to your team to discuss any problems. If treatment is needed, and it would be either anemia or symptoms of hyperviscosity, any of the symptoms we discussed earlier, then the treatment will be offered. Again, there are lots of treatments. I would just go with what I've mentioned here. There are supportive treatments, which would be plasma exchange. So sometimes when the protein is really, really high and patients have hyperviscosity symptoms, we try to physically remove the antibody from the body. So it's like a hemodialysis machine where you are attached to it, and we kind of take the body out of the serum and return you donor proteins, healthy one. So it's not going to last, of course. It's done only as an emergency. But then patients need definitive treatment to really cut down the number of the abnormal cells in the bone marrow to stop production of this paraprotein. We use chemotherapy drugs, we use monoclonal antibodies, we use steroids. I have actually only mentioned the drugs here which are routinely available on the NHS, but you might read about other antibodies, about other biological therapies, and it just gets a little bit hairy because some of these drugs are not licensed or approved in the UK for use. And the difficulty is because Waldenstrom's, even though we have quite a few patients, there is quite a few around, it's still considered as a very rare disorder. And if there are no large clinical trials done for patients with rare disorders, the evidence is not there, and it's then difficult to convince the commissioners in the UK, oh, these drugs are good, can we have it, please? So quite commonly, if you require as a front line of treatment of patients TB, would be using something called DRC. That's dexamethasone, that's a steroid. R is rituximab, that's an antibody, and C is cyclophosphamide, which is a chemotherapy tablet. Or if patients have a bit more aggressive disease, or we need a really fast response, we would be using BR, which is bendamustine and rituximab. So we always combine the chemotherapy with the antibody. And as a second line treatment, we use now targeted therapy, little molecule, just a Bruton kinase inhibitor. So some patients are still on ibrutinib, but that's now been kind of stopped use, and we use zanubrutinib in the UK. So I don't want to, because you are all very early on in your journey, I don't want to flood you with information. I mean, the literature is there. The WM UK is providing quite a useful overview of all the drugs available. So I think I would just leave it at that. I think what is important is, if your center has got access to clinical trials, it's always good to offer patients clinical trials, because that's how we actually gather the important information. So for frontline therapy, we currently run Rainbow study. It's done from St. Bart's by Dr. Rebecca Auer. And there are a few studies as well for the relapse and the relapse setting, which you don't need to worry about at the moment. Things will move on and evolve. So if you like numbers.
Sorry, Dr. Lindsay, could I ask a question? I'm just thinking, one of the things that we're really keen at WM is for people to live well with their Waldenstroms. And like you say, many people won't need this type of treatment intervention for many, many years, if ever. I wonder, is there anything that you would recommend to people that might help them to kind of stay well? You know, so I know that at one point during COVID, there was a lot of recommendation for people to take vitamin D because it was helping if you were immunocompromised. You know, is there anything like that that would be helpful for people that isn't active treatment but might help them stay well?
So generally, stay positive and active. Okay, so it always helps. Physical fitness is very important. So if you can, just stay physically fit, because it's got a good influence on your general well-being, but also when it comes to time you need treatment, fit people do much better. You know, it's not a rocket science. In terms of supplements, vitamin D has been shown to be very beneficial in cancers in general. During COVID, of course, because of isolation, we didn't get outside exposure. So vitamin D, yes, it's recommended. I don't think there are no randomized studies to say if you take vitamin D, you do better than if you don't take it. But there is enough evidence now from little reviews that vitamin D is beneficial. Eat balanced diet. And just be happy if you can. I mean, which is the difficult one, because, you know, people say, oh, you've got cancer. Oh dear, what now? Now I'm just waiting. Now I'm just waiting for chemo. Just try to join the group, talk to people, and you will find people who have not had treatment for 5-10 years, or had treatment and haven't needed one for 10 years. I think these positive news are very important to well-being, but there is nothing extra you can do.
Just general
things.
Healthy living and active.
Absolutely. Yeah. Okay.
It's the fatigue that kills that activity. That's the problem.
Yeah. I know, David, and I hear you, and it's a tricky one. I think you do need to kind of repeatedly discuss this with your doctor, because the COVID just made it all difficult. So obviously I can't really advise here, because I don't know your story, I don't know your results. But if the fatigue is really, really stopping you, just do talk to your doctor. Anyway, I thought I'll just sorry.
Now, on your list of treatments, you had steroids there. Is there a downside to steroids or an upside? My particular story was, it took a long time for somebody. Our surgery actually went bust, and we had lots of locums, so I don't think I ever saw the same doctor twice. But anyway, one particular doctor gave me steroids for 6 days just to see if it had any effect. But the one noticeable effect it did have was on my hand-eye coordination. We have a fun game in the Southwest, because that's where I live, called Skittles, which happens in the evening. But anyway, my hand-eye coordination when I was on those steroids was 10 times better than it was without them. So I'm not sure if there's
sports enhanced.
Steroids are stress hormones. So our body produces steroids. We produce steroids a lot if we are in a stressful situation. So adrenaline kicks in, and it just starts producing all these steroids. So we're going to the war, we're going to kill a bison, you know, that's when steroids kick in. You were given relatively high dose of steroids, which are normally produced by your body, but at a kind of much more control level. So patients quite often like steroids because it gives them the boost. But also steroids will suppress some of the immunity and make you more vulnerable in terms of other infections. So, it needs to be very carefully decided, why am I giving you steroids? What am I thinking is wrong with you? And understanding. So blindly, I wouldn't give patients steroids. I would like to have a good reason. Okay. But yeah, you improved.
Yeah, it's very short-lived, but yes.
Yeah. Okay, here we go. So there are some data for you, and it's just, I think, particularly the bottom one, the smoldering Waldenstroms, it actually shows that if the disease progresses, it progresses for almost 2/3 of the patients within the first 5 years. But then, kind of, if you plot this on a chart, then you will realize after 5 years, if your disease does not progress to something which we call needing to treat, that after 5 years it kind of levels. So, yeah, I don't know how. I mean, you are all kind of relatively early into your diagnosis. So, if things gonna happen, they're gonna happen within 5 years, and then just kind of get stuck. I'm aware of the time. So, prognosis and follow-up. So, as I mentioned before, it is an indolent disorder. The median survival is over 10 years. Sometimes, if and when you start treatment and you need treatment, the doctors will be talking about the international prognostic staging for WM, and it just looks in what's your age, what's your level of hemoglobin and your platelet count, and there are some other blood tests they do. So that's just used for prognostication, and that will develop, but that's purely used when patients need treatment. So it sounds like majority of you are on monitoring at the moment. There is currently no cure, so it is very likely that when you get a treatment, the disease will calm down, and then it will need to be retreated again, because you all look very young, so you probably hopefully have another 15, 20 years ahead of you. So, that's very likely that if you do need a treatment, then you will need another one. And because of this nature of the disease, that it is something you will be following with your doctors forever. So long-term follow-up is needed. And I think this, again, I would stress out, and I've mentioned it a few times, please do make sure that you know who your point of contact is. You should have your clinical nurse specialist, because it's very important if you develop any new symptoms which don't make sense to you and you're worried, and you've got someone to contact and discuss it with them, because as I said earlier, there are some weird and wonderfuls and rare conditions, and we can't provide you with literature on every single symptom, but you need to have someone who you trust and you can contact and you can discuss things with them. So, and this is where I am on my holiday. That's the quiz question.